So, good morning, everybody. I would like to welcome you to today's resident lecture. It's my pleasure to introduce Petras Laurinavicius. Petras is a third-year resident. He studied medicine in Lithuania and came then to Switzerland to train as a surgeon. He began in a small hospital in the near of Bern, then moved to the cantonal hospital Uri, and is now at the US set since August 2021. He will give us an update on intestinal bowel obstruction, so please enjoy.
So good morning, everyone. As mentioned before, today's topic is the intestinal obstruction, and I would like to start with my table of contents. So firstly, I will give you a brief introduction on definition and epidemiology, followed by the classification of this disease. Afterwards, I will talk about the mechanical obstruction, with adhesive small bowel obstruction being the main topic of today's presentation. At the end, I will give a few words about malignant large bowel obstruction and postoperative ileus. To start with, the word ileus comes from ancient Greek language meaning intestinal obstruction. However, it is worth mentioning that in English-speaking countries, the term ileus is referred to a failure of normal intestinal motility without the absence of mechanical obstruction. And if the mechanical obstruction is present, the term intestinal obstruction should be used. So the bowel obstruction causes nearly 30,000 deaths and up to $3 billion in direct medical costs per year alone in the United States. It is responsible for up to 15% of emergency admissions for acute abdominal pain, with 20% of those cases needing surgical treatment. There are many ways that one can classify the bowel obstruction, and I would like to start with the cause of it. So, firstly, we can have a mechanical barrier that is directly blocking the passage through obstruction, strangulation, or compression. Or we can have a functional problem, which is a dysfunction of intestinal muscles, and it can be paralytic, reflectoric, or postoperative. We can also classify the bowel obstruction according to its localization. It can be either in small or in large bowel. And I would like to ask my fellow residents, what are the main causes of the intestinal obstruction according to its localization?
I think for small bowel, it's usually due to adhesions. And for large intestine, it's mostly colorectal cancer.
That is absolutely correct. So the adhesions are leading cause in small bowel obstruction, causing up to 75% of the cases, followed by hernias and malignancies. And in large bowel, cancer is a leading cause, followed by volvulus and diverticular disease. Moving forward to the mechanical obstruction, I would like to start with the pathophysiology of it. So firstly, it causes the stasis of intestinal contents, which on itself has two consequences. Firstly, it increases the release of bacterial endotoxins, which can cause loss of the mucosal barrier and the translocation of bacteria. That can lead to peritonitis, bacteremia, and endotoxinemia, which can end up in sepsis. Secondly, the stasis increases intraluminal pressure, which can cause the shift of fluids and electrolytes into third space, which can cause electrolyte imbalance and fluid loss, and can end up in multi-organ dysfunction and shock. As I've mentioned before, ASBO will be my main topic today, and why is it so important? Well, in the general population, it is responsible for up to 1% of all emergency admissions and up to 3% of all laparotomies. However, in a population of patients following surgery, it causes up to 9% of all admissions, with 1/3 of those patients requiring operative intervention. It does a considerable harm, causing 8 days on average of hospitalization, and it has up to 3% of in-hospital mortality rate per episode. There are many risk factors for ASBO known, and the main one is the surgery. And one of the most comprehensive efforts to evaluate the burden of adhesion-related morbidity was undertaken by the SCAR group in Scotland. The investigators utilized Scottish NHS database and came up with almost 13,000 patients who underwent visceral surgery within 1 year. Those patients were followed up for 5 years, and the investigators looked at the adhesion-related readmission rates. What they found out was that the patients undergoing an index operation of ileum has the highest risk of developing ASBO with the risk of 7.7%, followed by those undergoing abdominal wall or colon surgery. In other systematic review made by Dr. Bamparas, 62 studies were included with almost 450,000 patients after gynecological and general surgery operations. They also looked up at the adhesion-related admission rates, and they found out that the patients undergoing open adnexal surgery had the highest risk of developing adhesions and ASBO, followed by those undergoing ileal pouch anal anastomosis, open total hysterectomy, and open colectomy on a fourth place. They also looked up and compared the technique of operation and found that the laparoscopic surgery has a significant lower risk for ASBO. The other risk factors known are the age under 40 years of risk, which is independent risk factor for recurrence of this disease. Penetrating abdominal trauma has incidence of 7.3% for ASBO. Gallstone spillage during cholecystectomy increases the risk of ASBO because of the inflammation that the gallstones produce as a foreign bodies. And there was no gender difference reported in the studies. When we talk about the ASBO, it is important that we define different types of adhesions, and there are two of them. Firstly, we can have single band adhesions, which are typically shorter than 1 centimeter and thicker than 1 centimeter. However, as you can see in this image below, there can be extremes where single band adhesions can be really long. They cause SBO through external compression, and high-grade obstructions and bowel ischemia are more frequent with this type of adhesions. Other type is the matted adhesion, which are multiple, dense, and tangled, and they are the most common cause of frozen abdomen. The clinical presentation of small bowel obstruction in general is colicky abdominal pain, nausea, and abdominal distension. It is a common misconception that the patients with ASBO are not allowed to have stool or wind. However, this is false because stool and wind resistance is a late symptom, as diarrhea can be reported up to 24 hours because of increased peristalsis distal from the obstruction. And if the obstruction happens to be proximally, we can have enough bowel content left. Although ASBO is a common condition, the diagnostic and therapy are often based on surgeons' personal preferences rather than evidence-based protocols. Therefore, the World Society of Emergency Surgery developed guidelines, which are called Bologna guidelines, to support clinical decision-making on diagnostic and therapy of ASBO. The newest guidelines were published in 2017 in the World Journal of Emergency Surgery, and they are openly available for everyone. The algorithm starts with initial evaluation of the patient, including history taking, which amongst others should be focused on previous operations. Physical examination includes the symptoms that we have discussed before, and the lab results are mostly nonspecific. What we can expect are the elevated infectious parameters such as white blood cells and CRP. If we have the suspicion of ASBO, we should go with further diagnostic, and in the best case scenario, it is a CT scan with water-soluble contrast. And this on itself has two aims. Firstly, we have to look for signs of intestinal obstruction, and we have to look for red flags. Why CT is the gold standard? Well, of course, of its high sensitivity and specificity. There are many studies made that evaluate CT as a diagnostic tool in the patients with ASBO. I've chosen one meta-analysis made by Dr. Lee, which included 42 retrospective studies with 4,000 patients diagnosed with ASBO in whom CT was used as the index diagnostic tool. What he found out was that the sensitivity and specificity for detecting SBO was 91% and 89% respectively. The sensitivity of predicting adhesions as the cause of SBO was as high as 95%. And the sensitivity and specificity for bowel ischemia was 82% and 92% respectively. So I would like to ask you, what are we looking for in a CT scan if we have a suspicion of intestinal obstruction in small bowel?
Intestinal dilatation, small bowel feces sign, or free fluid, free air, or some single band adhesions.
Yeah. So basically 3 signs are defined as the main ones. Firstly, we can look for intestinal dilatation, and the cutoff diameter is 2.5 centimeters. Secondly, we have to look for small bowel feces sign, which is a fecal material mixed with gas bubbles within the lumen of small intestine, which resembles colonic content on a CT scan. It is a result of delayed intestinal transit, and is caused by bacterial overgrowth, incompletely digested food, and increased water absorption in small intestine. And thirdly, single band adhesions can also oftenly be seen on a CT scan as presented on this image. As mentioned before, the second aim of a CT scan are the red flags, and there are 4 red flags defined by the Bologna guidelines, and 3 of them can and should be seen on a CT scan. Firstly, it is a closed loop or strangulation, which is defined as a specific type of obstruction in which 2 points along the course of the bowel are obstructed. In this image, we can see dilated jejunum, which is marked with an arrow, with narrowings both proximally and distally, which are marked with arrowheads. You can note that the proximal bowel is dilated and filled with contrast material. And it is worth mentioning that the closed loop has a high risk of ischemia and intestinal necrosis. The second red flag is the bowel ischemia on itself, which can have multiple signs on a CT scan. Those being thickened wall of intestine, heterogeneous enhancement, mesenteric edema, free intraperitoneal fluid, and pneumatosis intestinalis, which is finding of gas within the wall of intestine. The third red flag is a free intraperitoneal air, which should lead us to a suspicion of abdominal organ perforation. The fourth red flag is the peritonitis, which is of course a clinical finding. And if any of these red flags are present, the patient needs emergency surgery. Otherwise, it is not indicated, and we should go with a conservative trial. And maybe someone could tell me what are the key points in the conservative treatment of a patient with ASBO?
So you should give nothing per os to the patient. You might administer IV fluids, and it's important to insert a nasogastrical tube, and you should use water-soluble contrast material.
Yeah, that is absolutely correct. Those are the main treatments. Nothing per os, intravenous fluids, and nasogastric tube for decompression of the stomach. And water-soluble contrast should be applied, followed by imaging series with X-ray. And if we can see contrast in 36 hours in colon, we can call it the resolution of ASBO. Talking about the gastrographin or other water-soluble contrast materials, although they are included in the Bologna guidelines, there is no common consensus between the study groups, and the results of its usage and on diagnostic and therapy are not unified. In the last 2 decades, there were 4 meta-analyses made, which analyzed its usage for diagnostic and therapy of ASBO. 3 of them showed that it had pretty high sensitivity and specificity for prediction of resolution of ASBO, that it reduces length of stay by 2 days on average, and 2 of those meta-analyses showed that it can reduce the need of surgery. However, the last meta-analysis, which is also the newest one and was published in 2020, showed that it does not reduce the need for operative management in ASBO, nor does it impact mortality rates. It shortens hospital stay, but by only 3.6 hours, which is not clinically significant. So, if we don't see contrast in 36 hours or colon, or if the conservative treatment fails, that means if we have persistent obstruction for more than 72 hours, if the drainage volume is more than 500 milliliters on a 3rd day, or if the patient develops signs of peritonitis or ischemia, we have to go with surgical exploration, and the gold standard of it is the laparotomy. We can attempt laparoscopy if we expect single band adhesion, if the patient had less than 2 laparotomies in history, and if the surgeon brings enough experience with him. There are not many studies that compare laparoscopy against laparotomy in the treatment of patients with ASBO. The first randomized controlled trial comparing this was published in 2019 by the colleagues from Finland. It was published in The Lancet. They took 100 patients, and it is worth mentioning, they have excluded those having signs of strangulation and peritonitis. They have excluded the patients having higher risk for matted adhesions, for example, previous operation for endometriosis, previous generalized peritonitis, more than 3 previous open abdominal operations. And they looked at 2 groups, open surgery and laparoscopy, and compared them. And they found out that in this specific group of patients in which we expect single band adhesion, laparoscopy shows better results, reducing the length of postoperative hospital stay, reducing mean time to bowel function, reducing the need of epidural analgesia, and the length of sick leave. Although laparoscopy and laparotomy are different techniques, the general principles of adhesiolysis are the same, and sadly they are not unified. We can tell some general rules, for example, that we have to look at all of the intestine from Treitspont to ileocecal wall. We have to remove all of the adhesions, not only the one that is causing the problem. We have to operate atraumatically, and it is worth mentioning that bipolar electrocautery and ultrasonic devices do a lot less damage to peritoneum than monopolar electrocautery, and intestinal and bowel resection should be undertaken by irreversible damage through the adhesions. For a long time, we had this dogma that the patients with intestinal obstruction have to be operated quickly. However, in the last decade, there were many studies that have proven otherwise. For example, retrospective trial by Dr. Scharfnagel included 27,000 patients that were diagnosed with ASBO and that were initially treated conservatively. 4,800 of those patients required surgery sooner or later. And what they found out, that the cutoff for increased postoperative length of stay were 4 or more preoperative days, and that mortality rates increased after more than 3 preoperative days. Other retrospective trial made by Dr. Bauer included 460 patients diagnosed with ASBO. 106 of those patients needed surgery within the first 24 hours because of concerning clinical and radiological findings. 254 patients required surgery after the 24 hours, and they compared those early surgery and delayed surgery groups and found out that there was no significant difference between bowel resection, stomach reaction, and postoperative complications. However, it is worth mentioning that those results were not statistically significant. So I hope you had a pretty good insight into the diagnostic and therapy of ASBO, and I would like to move forward to the large bowel. And as I mentioned before, the main cause of the obstruction in large bowel is the cancer, and the acute malignant large bowel obstruction causes up to 80% of all emergency presentations in colorectal cancer patients, and it is the initial symptom in up to 30% of them. The clinical symptoms include obstipation and cramping abdominal pain, which is different than the pain described by the patients with ASBO. The gold standard of diagnostic is a CT scan, and it is worth mentioning that up to 75% of those patients require surgical treatment. And it is standardized by the guidelines of World Society of Emergency Surgery according to the stability of the patient and to the localization of obstruction. However, as it is a broad topic, I will not go further into the details. At the end, I would like to tell a few words about the postoperative ileus. And the postoperative dysfunction of intestinal muscles is actually a physiological finding up to 72 hours according to the localization of the surgery. However, if it is prolonged and causes abdominal distension, vomiting, oral intolerance, and delayed elimination, it is pathological and called postoperative ileus. It is a pretty common condition, appearing in up to 17.4% of the cases after the colorectal surgery, for example. It is worth mentioning that it is a completely reversible condition, and there are many preventive factors known. They are all included in the enhanced recovery after surgery protocols and are divided into pre, intra, and post-operative. And I would like to mention a few of them. So firstly, it is the epidural analgesia, which can accelerate the return of flatus by up to 17 hours. Secondly, the laparoscopy on itself can accelerate the return of flatus by up to 24 hours. Thirdly, the liberal fluid usage during the surgery increases time to first bowel movement up to 2 days because of the edema of the intestines. That's why the restrictive fluid usage should be undertaken. And lastly, chewing gum can accelerate the return of flatus by up to 12.5 hours postoperatively. So my take-home messages are that the most common cause of small bowel obstruction are the adhesions, and the clinical presentation of ASBO are abdominal pain and nausea, and stool and wind resistance are the late symptoms. CT scan is a gold standard for diagnostic for both ASBO and acute malignant large bowel obstruction. And in a CT scan, we have to look for red flags because they are the indications for emergency surgery. Otherwise, conservative trial should be undertaken, and it is allowed to last for up to 72 hours. Acute malignant large bowel obstruction almost always needs surgical treatment. And talking about the postoperative, ileus, epidural analgesia, laparoscopy, restrictive fluid use, and chewing gum are preventive factors for it. So thank you very much.
Dear Petras, thank you very much for this lecture and this great overview of intestinal obstruction. I think it's very important that everybody is familiar with this disease and knows how to manage patients with intestinal obstruction, as it is one of the most common reasons for emergency admissions. The most common cause for intestinal obstruction are adhesions, and the Bologna guidelines provide us with an algorithm for diagnosis and therapy. However, I think it's important to not act stubbornly according to these guidelines, but to do the decisions individually and looking for the patients. I also would like to emphasize that the initial assessment of the patients is crucial. So first of all, you should do diagnosis quickly and correctly. And second, you should look for complications. And if you have signs of peritonitis, strangulation or ischemia, so in most cases you have to go for surgery. If you find no red flags, so you can attempt for a conservative treatment. However, I think it's important that this decision is made by a surgeon and that the patient after that is admitted to a surgical department. And the patient, in case of non-operative treatment, must then be really observed regularly to not miss the situation where you have then change your treatment and go for emergency surgery. That's so far from our side. Are there any comments or questions in the audience?
Yeah, I may start. Number one, congratulations. Absolutely superb presentation of a common disease, and I'm very impressed by the fellow who come from Lithuania. Do very good presentation, doing very well with us. I did not know about the chewing gum, so I learned something here today that we need to give chewing gum. One question or maybe a comment is you have shown as other disease the continuity of care, and today we have protected time or whatever, and you have different people. I think it's very important when you follow these patients. Optimally, it's the same people who see them at admission, 24 hours, and then at 3 days make the decision. You highlight pretty clear criteria, but still clinical examination is extremely important to see which direction it goes. So more our comment today is that communication is important. I think you cannot have someone 3 days on the bedside, but that is a very good communication, and the one who take over maybe together with the previous resident or attending go to look at the patients to not miss the time when surgery is needed or not needed. Mostly a comment on this, but again, congratulations, excellent presentation.
Thank you very much. Also from my side, I think that was a really, really good presentation. I just have two comments to make. First of all, regarding the chewing gum, I'm a bit surprised that showed up in your up-to-date analysis, because there was a large meta-analysis published about 4 or 5 years ago that was looking at chewing gum use, and it was found to be of no significant use in the post-operative period, but maybe the evidence has changed in the meantime, so I'm happy to look into that myself. The other thing is you showed incidence rates for adhesive small bowel obstruction following different operations in one of your very first slides. And that was interesting to see, although I'd just like to mention that those incidence rates will vary greatly according to the axis used. Whether these operations are done open or laparoscopically, as you have mentioned at some point down your talk, will make a big difference. For example, in operations for ulcerative colitis, where we do staged resections, we see very clearly that those patients undergoing laparoscopic total colectomy, they will show almost no adhesions in their second operation, whereas those patients who have undergone open total colectomy, as you've nicely showed, they show a great number of adhesions typically. So I think the access route makes a lot of difference. And I think that's one of the driving factors also that should be noted for the push towards minimally invasive surgeries, just simply because we have a means to avoid a good part of these problems. Other than that, thank you very much. I really think, like I said, excellent presentation. Thanks.
Okay.
Thank you very much.